For those of you here in this room, you've met me. My name's I'm Rajni. I'm one of the consultants here. And for those of you at the Royal, I'm one of the consultants on ICU, but I also do thoracic anesthesia. So some of you at the Royal might have rotated through to Glenfield as well, so you'd have come across some of these patients. But if you haven't and you're going to be coming across, then this is generally what happens with thoracic patients. So basically, we did the outline for this talk, and it's not going to be very long, but the outline for the talk is we'll talk about non-surgical complications, surgical complications, and maybe some of the modifiable risk factors as we go along. So the non-surgical complications, if those of you who've had a bit of experience with managing these patients, you'd know that they are fairly high-risk patients with multiple comorbidities. They are, in general, at the higher age group, smokers, quite likely to have COPD, but certainly to have smoking-related lung disease. And along with that, the cardiorespiratory diseases, vascular diseases as well. So the non-surgical complications, of which the common ones would be amongst the cardiac complications, you get arrhythmias. Quite commonly, you get pulmonary hypertension. You can get some post-operative MIs as well. So it is a bit rare to have post-op MIs, but it can happen. The commoner or then the cardiac complications and the respiratory complications. And the respiratory complications rarely are atelectasis. And that is because, as the nature of the surgery itself, they would have had, lung collapsed and re-expanded during the surgery. So that in itself can give you some atelectasis. You could also have, because the pre-existing lung condition, especially if they've had, say, some ILD, if they've had some restrictive lung disease, and you can have hypoxia related to that. You could have a little bit of pulmonary hypertension creeping in, so you could have a bit of hypoxia because of that. It also depends on the amount of lung you've taken out. So these days you don't see significant post-op hypoxia because you do a lot of wedge resections, whereas in the past we used to do more extensive resections. Even if it is a small tumor, patients would more likely to have had a lobectomy. Pneumonectomies are quite few and far in between these days. So it depends upon the extent of surgery as well for you to have that postoperative hypoxia. And pain can be quite significant in these patients because thoracotomy pain is one of the most severe pains, postoperative pains that you can have. And the reason obviously is that they cut through the ribs, they can cut the intercostal nerves. So and as you try to breathe, and we expect them to tolerate quite a lot of physio, coughing, all of that kind of a thing. So acute pain can be quite significant. And the gold standard here for management of pain is epidural still. So most of our patients will get epidurals. The trend nowadays is to go towards planar blocks. So blocks such as the paravertebral blocks or ESP blocks, serratus anterior blocks. So the sort of things that we tend to do. The surgical complications, which are early ones, as always with any surgery, is bleeding. It is quite uncommon. Blood loss in thoracic surgery, contrary to belief, and contrary to the fact of where they're operating, is actually quite rare. You don't really get massive bleeding. If you do, then it is catastrophic because they would have gone into a pulmonary vein or an artery, and if it is uncontrolled, then that could be catastrophic bleeding. The commoner ones are air leaks, really. So that's the commonest complication, post-op complication, surgical complication that you get a persistent air leak, and that could be from either a bronchopleural fistula or just that the patient has got massive emphysema. And their bullous disease all over, which give you the persistent air leak. Rarer complications are cardiac herniations, and we'll talk a little bit about them. Torsion of the lung, again, quite rare, but that does happen. I have seen it. And really late complications are cancer recurrence and bronchopleural fistulas. So the reason for post-op hypoxia, as you can see on this slide, is the chest is open, patient is on the side. So if you remember your respiratory physiology, the bottom bits of your lungs are the most compliant bits of your lungs. The top bits are not that compliant. Whereas here, because the bottom bits of the lung are squished between the table, the open chest, the surgical hands present in the chest, the mediastinum pressing on the lung, and then from the bottom there's the diaphragm that has become, that pushes onto the lung. So you can have that bit of the lung is quite squished, but that's the only bit you're ventilating. The top lung is down. You're not ventilating the top lung. But apart from that, your blood flow is also compromised from the top lung in terms of shunt. So the lung is collapsed. Your small blood vessels, the capillaries, arterioles, are all squished as well because of the weight of that. But at least 20% of your cardiac output is still going to the top lung because you're not squishing the major vessels, isn't it? The major pulmonary artery, pulmonary vein, the bronchial arteries and veins. So blood is still flowing through those vessels. So you will have a large portion of shunt, and that does impact on how you ventilate them intraoperatively. Okay. So that's some of the reasons. And when you then, at the end of surgery, you undo the clamps, you ventilate both lungs, you give them more than 21% oxygen. So you are ventilating them at higher FiO2s, which also causes some atelectasis. So those are some of the reasons why you would have post-op hypoxia. So as we've said, the causes for post-op hypoxia could be surgical manipulations, as we've already said, because they're moving around, they're releasing quite a lot of inflammatory mediators, and that causes quite a lot of vasodilation in that bit of the lung. And there is something called hypoxic pulmonary vasodilatation, which you guys, your non-anesthetic trainees would not really be very familiar with. But basically what this is, the lung, wherever there is hypoxia in that bit of the lung, because the lung is trying to optimize perfusion and ventilation, the vessels dilate over there. So, and that can be compromised with some of your anesthetic techniques and things like that. Okay. So, and that's why the hypoxic pulmonary vasodilatation is quite high in people at high altitudes. So intraoperatively then, if your ventilatory technique, again, can impact on postoperative function. So if you were to use high tidal volumes, traditionally we were told 10 mils per kilo body weight to ventilate and keep them oxygenated. But if you were to use such high tidal volumes, particularly on one lung, then you're over distending the lung and causing a problem. Okay, so and as with everything else, as with any other organ where you clamp blood supply, you get that reperfusion injury. So you've clamped it, you're unclamping it, so there is ischemia reperfusion injury as well. Massive transfusion, as I've said, is quite rare. You get a need for massive transfusion in very, specific surgeries, such as, say, empymas, so decortication, where there's an infected surface and you're peeling that surface off. That is where you get it. Or even for mesotheliomas, where you're doing pleural surgery and you're peeling the pleura off the surface of the lung, you can get blood loss up to 2 liters, 2.5 liters in those situations. But other than that, it is actually quite rare to have massive transfusion requirements. Now, the predictors of lung injury really is excessive fluids. So traditionally for thoracics, we don't give lots of fluids. We limit the amount of fluids we give. And that's why, Sarah, we only keep 500 mils of bags in thoracics. That's the reason, because, once you put the cannula in, you open the tap, 1 liter can quickly go through. But so the reason for stocking only 500 mils there is to stop us giving them too much fluid. Pneumonectomy is a predictor of lung injury, and the reason for that is especially right-sided, because the right-sided lung has got a larger lung volume than the left side does. So, and if you were to take that large volume out, you tend to you're at risk of pulmonary hypertension. So pneumonectomy, and when you have just the one lung and then you've given them lots of fluids, that is an independent risk factor for postoperative hypoxia and pulmonary hypertension, right-sided failure, and all that sort of a thing. So if you've given lots of fluid and the patient is having lots of urine output, then that would be an indicator that you've actually given them too much fluids. Okay. High alcohol intake, high airway pressures, the way you would ventilate them would be a risk factor for post-op hypoxia. Not entirely sure why high alcohol intake would be a risk factor, but it is quoted as a risk factor. And it commonly occurs at about 1 to 4 days post-operatively. Okay. So again, just going back to talking about this post-pneumonectomy hypoxia, it is rare. About 4% of all pneumonectomies can get this postoperative hypoxia. But if they do, mortality is really high. It's about 30 to 50% is high mortality. And the reason, as we've already said, is because what happens is there is vascular remodeling, inflammatory markers, remodeling, and the fact that your entire cardiac output is now going to one lung. So there's volume overload. Whereas, in the past, you would have had 40% going to the left, 60% going to the right. Now, all the cardiac output is going to one lung. And also remember, if this patient has needed pneumonectomy, they will have some lung pathology in the remaining lung as well. So that's part of the reason why they then end up going into right ventricular failure and increased mortality. Mechanical ventilation would actually cause more problems because ventilation usually is not a good thing for you. So if you were to continue to mechanically ventilate these patients, then the risk of mortality increases upwards. So cardiac complications, as we've said, arrhythmias are the commonest, of which AF is the commonest. The problem with these patients is, in practice, we don't really come across this that much, but you try to avoid giving them amiodarone, you try to avoid giving them beta blockers. Amiodarone because of lung toxicity, beta blockers because they could be, bronchospastic, and you don't really want to give them further bronchospastic drugs. So you could, that could be that is the main problem. And we generally, again, in the past, most thoracotomy patients would have a central line. Our incidence of inserting central lines is really come down now, but I would definitely put a central line in patients who having, say, a major lobectomy or a pneumonectomy, because I'm anticipating them to have AF, postoperative SVTs and AFs and things like that, and have got cardiovascular compromise. That's the only reason we would do that. So that, and the associative factors would be preoperative cardiac disease, cardiac failures, MIs, preoperative rhythm disorders. Those would be your associative features. MI, again, is quite rare after thoracic surgery, but it does happen. If the patient has had an MI before, and then you are then and they need thoracic surgery in the immediate post-MI period, mortality is really very high if you were to operate on them before the 4 to 6 week period. If they do have an MI and you need to manage that, the thing would be if they were suitable for a PCI, and then you would then use a bare metal stent rather than using a drug-eluting stent, and make things complicated for yourself in the post-op period in terms of bleeding and nerve blocks and epidurals and that sort of a thing. So those would be, and if you were to want to do both cardiac and thoracic surgeries and a lung resection at the same time, the mortality is really very high. And the reason for that really is that, the stress of surgery, the stress response to surgery would be quite significant in these patients in those situations. Okay. So we've already spoken a little bit about post-op pulmonary hypertension. So if the patient has already got preoperative pulmonary hypertension, then post-op pulmonary hypertension becomes, the risk is much higher. And which is why we check, we didn't do this in the past, but we do now. We check on echoes, we check the right-sided function. So if the right-sided function is already compromised, then we would limit the amount of lung we would resect. And again, especially if you were to do, say, lung volume reduction surgery, in COPDs, those patients will have, fantastical pulmonary function tests. That FEV1 would be something like 20% predicted, 30% predicted. So in those sort of patients where their lung function is really compromised, you will look to see whether they'd be suitable. And though LVRS is a palliative procedure, or whether it is LVRS or endobronchial valves, they're all palliative procedures. Even for those procedures, you'd look at their preoperative pulmonary pressures. If they're high, then that would be the contraindication for surgery in those patients. Okay, I think we've spoken quite a bit about this, these bits that we were talking about. So again, careful pre-op assessment and intraoperative management. You could try inhaled prostacyclins. You could try nitric oxide, though it would be quite tricky to use intraoperative nitric oxide on one lung. It would be quite tricky, but in theory, it is a possibility. But the other thing would be phosphodiesterase inhibitors, such as milrinone, and oxymone. Those are the sort of drugs that you would want to use to reduce your pulmonary pressures. So the other complication that you could have, and it could sort of build up during the procedure, is a contralateral pneumothorax. So if you're operating on the right side, and you have, so that right lung is down, and then you then have a pneumothorax on your left side. So there's going to be a fairly dramatic presentation of, tensioning, high CVPs, and all the rest of it. So it can present in a very dramatic way, which is why in thoracics, we always do everything on the side of surgery. Your arc line, your central line is always on the side of surgery, and that is to prevent that eventually complication if it were to happen. And this particular thing, if you were to have a pneumothorax on your non-operated lung, is even more impressive if you've had a pneumonectomy. Yeah. Now, as I said, torsions, they're very rare, but can happen. And they generally happen within the first to 14 post-op days. So basically what happens is, if this really relates to surgical technique. For instance, especially on the right side. So if you were to have done, say, upper lobe or a lower lobectomy, but haven't secured the middle lobe. So normally what they do is they put a stay suture between the middle lobe and the upper lobe at the top, or the middle lobe and the lower lobe at the bottom. And why that then kind of secures the middle lobe and it's not sort of torn, because if you think about it, there's space in your chest cavity that is empty now. It was previously occupied by the lobe that you've taken out. So things can turn around and they can torsion out. We've had, I'll talk about that patient in a little bit. So you could, and the way you would see it would be extreme hypoxia, cardiovascular compromise. You would have shock, hemoptysis, and on chest X-ray and CT, you would see that there is consolidation and there would be infarction of the lung. Okay, and management of that is immediate theatre. Okay, so if you see this lady had an Ivor Lewis done, operated on, and she went to the ITU. And then I think it was the second or third post-op, the second day, where she was hypoxic and not really getting better. And they couldn't extubate her. So taken to CT, and she has torsioned her right lung. So all of that is torsioned. Yeah. If you go back.
Would we be able to make the image a bit larger by maximizing this?
Where is that?
On the top right of the scene.
Okay. Yeah, happy with that? So so you can see that sudden abrupt cutoff over there. So that was completely torsioned out. So she was taken to theatre. They tried to untwist the lung, didn't really help. She ended up having a pneumonectomy. Okay, so it can happen. It's not unknown. Okay. Going on to the other surgical complication, which is really of importance both from ICU and anesthesia point of view, is bronchopleural fistula. You can get it following pneumonectomies, and you can get it following lobectomies as well. So part of it is surgical technique, but some of it could be patient factors as well. So somebody who's, that's one of the reasons why we don't operate on patients with really low BMI, because of their poor nutritional status. We try to build them up before we take them up for surgery. So poor nutritional status, poor wound healing, diabetics, people on steroids, any necrotizing infections that might be there. Is it complicated? Okay. 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 And there's nobody out there, is it? Yes, nobody. Okay. None of the consultants there. Okay. So you could have somebody who's had, thanks, Sam. Somebody who's got, say, we do quite a lot of chemoimmune therapy now. So if they've had chemotherapy, adjuvant therapy, chemotherapies, or a long bronchial stump, because the perfusion to that stump can be compromised. A shorter stump is easier to maintain vascularity than a longer stump is. Post-op ventilation, that's where most of us, don't bring a patient ventilated back to, we don't bring them to ICU ventilated. Most of them extubated. And the reason for that, we need to have a really good reason to keep thoracic patients ventilated. And the reason for that is the constant positive pressure on the stump. It can give way. So it could be acute, it could be immediate, and if it is immediate, then the presentation could be quite life-threatening because it presents as a tension pneumothorax. There's sudden shortness of breath and the clinical features of tension pneumothorax, okay? But also there could be secretions, bloody secretions coming out, especially if it is in the acute post-op period. Subacute and delayed could more insidious presentations. They can present with wasting, malaise, cough, that kind of a thing. Generally, if it is a pneumonectomy and you've got a bronchopleural fistula following a pneumonectomy, then you get the mediastinal shift is not quite so dramatic, and that is because the space has now been filled with fibrotic tissue, and it prevents that shift, the mediastinal shift. Okay, so the consequences of a bronchopleural fistula, so you have a persistent pneumothorax, inadequate ventilation, VQ mismatching. And also there is the potential for soiling of the pleural space and soiling of the opposite lung as well. So your secretions, because when you breathe, the air is going to follow the path of least resistance, so it's going to go there, and then the secretions can move across and soil the other lung. So you're constantly having an infected space. Okay. So the management of these bronchopleural fistula really is, they can be tricky because you want to protect the clean lung from soiling, and B, you want to control your ventilation. You want to be able to ventilate and have airway control as soon as possible, really. So the first priority, protect the opposite lung. You would want to drain the space. You want to clean the space out. It would need to be organs, antibiotics, and eventually surgical repair of that fistula as well. So that fistula does need to be repaired. If it has been sitting in an infected space, it's not going to self-heal. Yeah. So airway control, everybody talks a lot about airway control of bronchopleural fistula. Generally, these patients, when they come to you, will have a chest drain. If they have a chest drain, keep the chest drain open. If they don't have a chest drain, they likely need a chest drain before you get started on controlling ventilation. Otherwise, you will have a tension pneumothorax, because when you're giving them positive pressure ventilation, all that air is going to go through the fistula into the pleural space. So you need to control the ventilation. You need to control that space. Okay. If there is no chest drain, you would consider spontaneous ventilation till you do have a chest drain inserted in. Now, this, as in anesthesia, you can have endless arguments and debates about whether you'd want to do an awake intubation or a spontaneous inhalational intubation or an IV intubation. For me, the best way of securing the airway in this situation is a quick IV induction. Quick IV induction, muscle relaxants. You could do them on the side. You could send them to sleep on the side, and then a quick control, airway control. And then you could use either a double lumen tube or a single lumen tube, or you could use a single lumen tube with a blocker. It's either way, really. So you could put a single lumen tube, sit the tube above the carina and pass a blocker which blocks the side that you want to block it, and then you could ventilate the other side. But always ensure that you have a surgeon around who can do a rigid bronch quickly, because that might then, because a rigid bronch, I don't know how many of you have seen a rigid bronchoscope. It's a metal tube that goes in, and you get good airway control, but most importantly, you'll be able to suck out all the secretions. It's a good metal tube to have ready at hand. Now, would you ventilate a bronchopleural fistula? You'll try not to. You'll try to wake those patients up, because any positive pressure ventilation on the stump can make it, can compromise the healing. And a lot of you could, I don't know if any of you, I think all of you are fairly young, would have seen high frequency ventilators. Yeah. So you could have, because what the high frequency ventilators do is the tidal volumes are about 2 mils per kilo. Just small tidal volumes, which you ventilate at a rate of about 150, sometimes even 300. Oscillators, you can ventilate them at the rate of 600 per minute. Jet ventilators generally sort of limit to about 300. So you're doing that, so the gas is flowing as bulk flow, but you're oscillating or jetting them at that rate. So you could use them. The main problem with high frequency ventilators is that we don't have the skills anymore. People are not used to setting those things up or to using those things. Ever since we've had the trial that showed high frequency oscillators don't improve outcomes. Okay. So this is a 2-week post-pneumonectomy. So you can see the fluid level over there, and you will not otherwise get a fluid level. You're getting a fluid level because there's a connection. There's air coming in and there's fluid over there. So that's why you're getting the fluid level. Otherwise, it will just be white, opaque shadowing. Okay. Again, cardiac herniation is very rare. So far, I've not seen it. But this happens if the pericardium has been resected, and if the pericardium has been resected on the right side, then, and it's not been closed appropriately, then the heart can herniate out on the right. And because it herniates out on the right, it can compromise the venous return. So when it compromises the venous return, you have no cardiac output and you have a cardiac arrest. On the left side, it is less dramatic. You could have, because if you know how the pericardium is, it's a hard, fibrous tissue. It can cause myocardial infarctions. It can compromise blood flow there. So which is why when we do surgery, say where we've had to resect the pericardium up, particularly in mesothelium and where the pericardium might have been involved, we always put a patch. So there's a patch that comes out on the pericardium, and the pericardium sac is closed. Okay, so goes without saying that it is emergency reopening, relocation, and closure of the pericardial defect. So the other thing that we have a little bit of an OCD about in thoracics is, how do you manage the chest drain post pneumonectomy? And the reason we have that, we are fairly careful about how we manage that is because what you're trying to achieve in pneumonectomy is that you don't want the remaining lung to herniate or the mediastinal contents to come across into the empty space. That is the goal. So what you do is you've got a chest drain in. Some surgeons don't even put a chest drain in. So they're trying to fill that space with fluid, which will then fibrose and consolidate and occupy that space and not allow the lung to move across. So, but if they do have a chest drain in, because remember this chest cavity has been opened and then they're trying to close it. So there will be some amount of air in that cavity. So all the surgeons that I know here in this hospital will put a chest drain in. So what we then do with the chest drain is you unclamp it for 1 minute every hour on the hour for the first 24 hours. So just 1 minute of unclamp, you drain some of the air out and then you reclamp it. Okay, so this is the one situation where we do not put the chest drain on suction. Yeah. Okay, so just a few examples of some of the weird and wonderful things that we see in thoracic surgery. So this is a gentleman who presented with stridor to clinic. What do you guys see on the CT and the X-rays?
CT, is it a foreign body?
That.
Yeah.
Yes. That slit is the trickier. Yeah. So he comes with stridor to clinic. So he's sort of fast tracked onto the ward, put on the list the next day for a rigid bronch and laser. So how would you anesthetize that? You're the only anesthetic trainee in the room.
So it depends on so he's coming with stridor, he's got urgent. So it depends on the presenting history as well, doesn't it? In terms of how acute it is, what is.
Does anybody at the Royal want to put the hand up? Let me know.
And what level it is, because I can't work out what it is.
No, so it is. The tumor was in the lower 1/3 of the trachea. So it was sort of. It was clearly away from the main carina. So it had about 3 centimeters or so above the carina, but it was in the trachea. So the carina was spared. So really, what you needed was a connection from sort of the mid-trachea to the carina, so you could ventilate the patient.
Yeah.
So
the intubation shouldn't be.
Yes, but then your tube would be an issue because your tube will be sitting above the tumor, really, isn't it?
To what the surgeon does.
Yeah.
Senior any.
Yes.
But the reason why you are.
I'm not. Adequate pre-oxygenation.
Yeah.
There's and probably nasal oxygenation as well, whilst doing airway stuff.
Yeah, you could do that.
There's not going to be any benefit in doing it awake versus sleep. I wouldn't have thought.
No.
The only thing I'm thinking is perhaps fibre optics, so you can try and bypass that.
But what if you touch with the fibre optic scope, you touch the tumor and it starts to bleed?
What about not intubating and immediately rigid bronch?
Yeah, exactly. Exactly, perfect. So that you wouldn't, because the problem with trying to intubate here is that whatever tube you do, it's going to be impossible for you to navigate it around the tumor because you can't see. And if you were to use a flexible bronchoscope, as soon as you touch the tumor, you could have bleeding and you lose all visibility. You can't see where you're going. So if you then if you then go with your tube through, you might be going through and through the tumor. So you would be blocking your tube with tumor. So if you were to go through and through with the rigid bronch, yes, you would coat the tumor, but you'd be able to suck it out and give you a reasonable, access to his bronchial tree. The thing, though, that you mustn't do is as soon as the surgeon says, I'm in, for you to start jet ventilating, because what you then do is you're jet ventilating above the tumor and gas is going past the tumor because it can do. It's not rock, so it will go through. But there is a ball valve effect in preventing it from coming back. So this patient had that, and he had bilateral pneumothoracis within about 3 or 4 puffs on the jet ventilator because air was going in, it wasn't coming out. Okay, so the thing to do really in this situation is to check with the surgeon that they've gone through and through. Yeah. So it does. It's rare, but it does happen. We generally don't use Thrive, but we could do, because if you are anticipating a difficult intubation, yeah, you could use Thrive. But Thrive, remember, is only about 2 or 3 years old, and we've only had it for a couple of years now in this trust. So you could use Thrive. It'll just buy you a little bit of time. But then eventually, whatever gases you're giving, whether you're giving it to Thrive or...
I was just thinking in terms of like ensuring you've got adequate oxygen.
Yeah, you could do.
You don't necessarily need to do it that way. Just do it.
Yeah. So this is a bad picture, but basically what happened is, again, the reason I put this here is to just sort of demonstrate how closely intertwined thoracics and cardiac can be. So this lady had a pneumonectomy and she was massively unstable in recovery. We couldn't figure out what was going on because she then started to build a metabolic acidosis. She was tachycardic. She was, started to drop her blood pressures. She wasn't in massive amount of pain, and then the drains were empty, so she wasn't bleeding, but she was having a metabolic acidosis, almost like something was going on intra-abdominally. And then when we did an echo, we saw that the IVC was massively dilated. And it turned out the surgeon had picked the IVC up in his sutures. So she then needed to go to theatre to go on to bypass and have that released and IVC repaired. So you can have, or you do need to be fairly vigilant in the post-op period when you have these. Complications are pretty rare too. If you were to look at the number of cases we do and the number of complications we have, it is not that common, but when they happen, they can be pretty dramatic. Okay, so this is a chap who had who came with a large adenocarcinoma of his right upper lobe and right lower lobe. His middle lobe was disease-free, but this didn't make any sense to leave that middle lobe and take the upper and lower. So he had a pneumonectomy, long procedure, and then he had post-operatively, he developed idiopathic thrombocytopenia, for which he received steroids. And which then meant he developed a bronchopleural fistula post-operatively because he had those steroids. So it all sort of, we then took him, he had a diaphragmatic repair of his fistula. And because he needed ventilating post-operatively and we were worried about the stump integrity, particularly on the background of steroids and everything else, we ventilated him on an LMA on ITU for the first 24 hours before we woke him up. So yeah, I think that's about it. Yeah, so that was his tumor. And again, the other thing that can happen on the table when you have such a big tumor is that you intubate them, you ventilate them, and everything is looking fine. They're on the back. You then take them into theatre, turn them on the side. Is the that weight of the tumors then drops onto the mediastinum and they lose their cardiac output. So it does, every little thing does have a big impact in what can happen. Okay. I mean, I have had to cancel a case because we could not keep a patient on the side. It'd be quite difficult. The surgeon didn't want to do it. We couldn't position her on her side. So he said, let's bail out. And that's his decision then, really, isn't it? I suppose he could have done a sternotomy. He could have this thing, but access was going to be much more difficult. Yeah.
But actually, the patient, him or herself, when they sleep on their sides, just one day or like
That's a
20
good
minutes
question.
prior to the surgery,
Yeah, that's a
they
good
don't
question.
get any of that, right? Is it because they self-ventilate?
Yes, yes. So that is the reason why that wouldn't happen, because they're self-ventilating. And then in your chest, they would have had difficulty lying on that side, and they would have kind of, without understanding why, they would have started to lie on the right side rather than the left side, or on the back. They would have made that adjustment. But generally, because it's self-ventilating, you're maintaining that negative intrathoracic pressure, which protects, yeah, which protects you to some extent. But even that amount of negative pressure is not going to protect you from that massive tumor sitting on your mediastinum. But generally, patients kind of, without understanding why they're doing it, self-correct what they're doing. I think that's about it, really. Any questions from the guys at the Royal? Okay. We've got Sarah here. I'm sure most of you know Sarah. She's our pharmacist, our ICU pharmacist. She's just going to talk to us a little bit about the GUARDS trial that we're doing. It's the glucocorticoids, steroids in ARDS. We are one of the recruiting centers for the trial in the country, and we're beginning to see quite a few patients come through with ARDS. So just sort of spreading the information a little bit, so patients are identified in good time to let either Sarah or myself or any of the other. We're trying to increase the number of people on the delegation log, so to let us know, and then we can come and screen and consent them for the trial. So I'm going to, if there's no other question, no?
I was thinking about this for our lady the other day, and see the mention about the bronchopleural fistula.
Which one are we talking about now?
Tensions.
Oh, yes.
But also with the bronchopleural fistula, so your concern when you intubate is that you're going to have positive pressure ventilate, positive pressure on that side. Could you, in theory, just intubate with a double lumen tube and then immediately like intubate onto one lung ventilation, or would that be?
You could. So the difficulty we had with that lady is that it was a device none of us knew how to use. Normally, when they come with a chest drain, you keep the drain open till you have had control of which side you want to ventilate them on. So,
But if say you didn't have a chest drain in, they don't have a chest drain at all, you don't want to positive ventilate that side.
Yes. So you could then, before you start ventilating, you put the double lumen tube in, if you're going to use a double lumen tube, and then ventilate just the side which is the good side. So you could do that. You could put a double lumen tube onto that side, or you could even put a single lumen tube into that side. So you could, especially if it is, say, the right side is easier to intubate with a single lumen tube, isn't it? So you could put that before you start ventilating. Or you could even, mount a tube on a bronchoscope, see where you're going, especially if it is, say, a left-sided bronchopleural fistula, or a right-sided fistula, and you want to intubate the left side. So use a bronchoscope, put your tube onto the bronchoscope, a single lumen tube, and then position your single lumen tube into the left side. You could, that's perfectly reasonable if you don't have a chest drain. And in those circumstances, using a Thrive might be useful to, keep them oxygenated. But again, Thrive is not a device that we've been using for a long time.
Yeah.
So yeah. Okay, so that's your so did you want to end?